Thank you very much for that kind introduction, and thank you all for being here. This is awful early in the morning to do a health policy, but we will try. I think that your conference focus on accountable care is most appropriate, and I think you're going to need to focus on this in this brave new world of healthcare. But my message is, if you don't include accountability for outcomes and costs, the consequences to the healthcare system can be quite severe. And I want to make that point by quoting two people who I think are healthcare experts. You may not. The first is Ben Bernanke, who is the former chairman of the Federal Reserve Board. I was recently at a meeting with him, and he described the United States government as an extremely large insurance company that also has an army. Now, the great irony is that we can afford the army, but increasingly we can't afford the insurance company. It's the cost of health care that drives our accumulated national debt. I'm going to talk about that in some length. And that debt is becoming a major threat to our economy. And according to the guy who used to run the Army that Bernanke talked about, who is Robert Gates, the former Secretary of Defense, it's this debt, our accumulated national debt, that's now funded in large part by foreign governments. And that has become a major national security issue. So if we want to have a growing economy, and if we want to avoid national security problems, we have to control the cost of health care. This is a message I hope I leave you with. It isn't about health care. It's about these other two issues, and the results are going to impact health care. So the multi-billion-dollar question is, how do we control costs and assure quality? And I think that you, as members of CAPG, have a great deal to offer. I remember the old days, the very old days. This was a much smaller group, and it was considered not mainstream medicine at all. Real men and real women, ran their own standalone practices. That ain't the future. And we've got to transform healthcare, and most of you are already partially, if not all the way there. Well, that's my take-home message, and I'm now going to shift to a slightly lengthier agenda. I want to cover these issues, but the question arises as to why any of you should listen to me. I looked at your program. I saw the people who are in the audience. This is a room that's filled with physicians, with nurses, with PhDs, with MBAs. And although Don was very nice to me, you notice there are no letters after my name. So the question becomes, on what basis does this guy presume to lecture to all of you? And it forces me to reveal a clinical credential which will astound and impress all of you. That's right. I am a licensed apprentice pharmacist. Now, in addition to never having seen a person with that credential, and I know how you are, it is the credential itself that is so important, because that document is signed by the only man ever to serve as governor of the state of Illinois, Chief Justice of the Supreme Court of the state of Illinois, and as an incarcerated felon in an Illinois state prison. So there's a lesson in that for all of us, which I prefer not to contemplate, and we'll talk about the agenda. First, I'm going to describe the accomplishments of the ACA over the past 5 years, and then what I see as the major challenge that we all face, and that is costs. Then we'll take a look at what the ACA has done about cost containment. Fourth, we'll look at the challenges for physicians, and I hope some of this sounds familiar to you, but it's difficult stuff. And then to provide some motivation, I'll describe the potential consequences of failing to control costs, and they are dire. And finally, there'll be a big finish with some free advice to all of you. Let's begin by looking at the results today of the ACA. According to Gallup poll, 11.9% of Americans are now uninsured. That's down from a high of 18% as recently as 2013. And according to RAND, 16.9 million people got insurance coverage are newly insured as a result of this bill. 87% of exchange customers qualified for subsidies, and this is why the Supreme Court decision is going to be so important, because those people could get messed about. 10.8 million people enrolled in Medicaid or CHIP. There has been a $7.4 billion reduction in hospital uncompensated care, and there have been 56 unsuccessful votes in Congress to repeal or undermine the law. However, the law has been significantly changed in many important ways. In fact, what's going on now is not terribly consistent with the letter of the law. There have been 23 changes that are significant by administrative action. There have been 16 congressional legislation that the president has signed. The Supreme Court made 3 huge changes, beginning with Medicaid. The federal government does not have the right to force an expansion of Medicaid, and we're waiting for the new ruling. And underneath all of this is something called Section 1322, which allows states to obtain waivers so they can do different things in different states. So this is a moving target, and one of my messages will be that it will continue to move, and it will move in ways that are unpredictable. Because, as I mentioned earlier, it's not about health care. It's about national security, and it's about the economy. And so in efforts to do something over here to benefit those two areas, things are going to happen over here that may have an impact on the healthcare system and on you. I think you're all familiar with the most recent and most significant change, the SGR fix, which establishes this 2-track payment model. I'm afraid I'm a little more skeptical than maybe others about this, because those quality metrics I think are open to some challenge, and I think there's going to be a lot of issues around them. I also think that doctors are not going to be happy about getting a 0.5% increase, and I think we're going to see a lot of lobbying around how that is done. Also, and most important to my major message, this bill increases the federal deficit by $141 billion, according to the CBO. So budget hawks are not happy, okay? This is not a, quote, good or responsible solution. And in fact, it highlights the fact that the problem remains health care costs. Now, I now teach, and I'm about to show you a slide that incorporates on one piece of paper an entire master's degree programs. So, every advanced country in the world attempts to do 3 things with their healthcare systems. They want to see that high-quality care is accessible to all their citizens at an affordable cost. That's what it's all about, and parenthetically, this predates the triple aim. This document, this brilliant triangular representation, I should say, goes back to when I was in the federal government, which is, as my daughter says, back when everything was in black and white. Anyhow, that's what everybody tries to do, and almost nobody gets it done. The best way to think about this is to stand back from healthcare for a minute and try to remember a movie of some years ago called Diner. It was a movie about several young men growing up in Baltimore who spent a lot of time at a diner. It was an interesting movie, but that's not the point. The point is that one of the characters in the movie was named Boogie, and it turns out that Boogie is a real person, and more importantly, it turns out that Boogie has a diner in Aspen, Colorado. Now, it's unusual because it's not a small little diner. It's actually a gigantic room, about half the size of this room and much higher. And on the far side is a gigantic poster, and it says, "Our food is fast, good, and cheap." And then underneath, in very small letters, it says, "Pick 2." That is healthcare around the world. Now, the sad thing is, here in the United States, we didn't even get to. We believed, or liked to believe, that we had the highest quality health care in the world, but that high cost was okay. This is a market economy, and different people make choices about how they're going to use their wealth. And if health care costs a lot and some people can't afford it, that's okay, right? Not a problem. What we now know is that we have extremely uneven quality, that there are some places, and hopefully all of your patients encounter this, where quality is very high. But basically, it's very uneven, and lots of people both get poor care, and even more people don't have access to care. And our costs are the highest by far in the world, and our results are nowhere near even average, okay? We pay more than any other country on earth for health care, and we get mediocre results. Now, when you add the high cost to a bad economy, and that's where we were until fairly recently, you really get a huge reduction in access to care. Now, this cost problem impacts all the way across our economy. First, it impacts individuals. Healthcare costs continue to go up faster than wages, despite the recent good news, and that makes it harder for people to afford it. It's also growing as a percent of GDP, and spending on healthcare, and I remember we used to say, my God, healthcare is going to be 8% of the GDP, what are we going to do? Everybody said, what's wrong with spending 8% on healthcare? Well, you get to 18% or 20%, and pretty soon it begins to crowd out other parts of economic activity. It also increases the accumulated debt, it increases interest costs, and that becomes a really serious threat to the economy. Alice Rivlin has said, and for those of you who are policy nerds, I think she's right, long-run fiscal policy, that is what our government and we do about our economy, is really healthcare policy. Now, as I mentioned, we've recently heard some good news, but although the rate of increase has slowed, it's back to growing faster than the rest of the economy, and that's not good, okay? So in other words, the rate of increase in healthcare costs exceeds the rate of increase, or will exceed the rate of increase in GDP by over 1% a year, which doesn't sound like much, but when you're talking about big numbers, it is a big issue. And longer term, these are CBO numbers. What we're going to see is healthcare costs increasing as a percent of the GDP. And this estimate says, and who knows if it's 100% accurate, but that will get up to 22% of the GDP by 2038. Well, what's wrong with this, okay? Well, in addition to the fact that it means that over $1 in every 5 in our wallets will be spent on health care, the real issue is who is doing the spending and how is that spending being financed. This is the second slide you need to memorize to get your master's degree. According to the CBO, the projected growth in federal spending is due almost solely to healthcare costs. Let's take a close look at this. The yellow bar at the bottom is everything the federal government does, except Social Security, healthcare, and interest on the debt. And as you see, it is dropping dramatically. This is the source of the comment about the Army. We can afford the Army, okay? That ain't the problem, okay? Now, Social Security is growing, but if you look at it, it starts big. It starts at about 5% in 2014 and only grows to a little over 6% in 2038. So it's a big dollar amount, but Social Security isn't the problem, and you can fix that in a pretty straightforward way. It's nowhere near as complicated as healthcare. What explodes is healthcare programs going from 4.8% to 8%, and interest on the debt. And interest on the debt is going up because healthcare costs have to be financed. So this is a major economic problem. And again, all of you are in healthcare, and I think all of you are knowledgeable. But this is the piece that's hard to see. It ain't about healthcare. It's about the economy. Now, lots of argument about deficits, are they good or bad? Most economists will say a 3% deficit a year is not a problem, provided over time you have surpluses. That's not our situation, okay? We have a huge accumulated deficit, okay? And according to the CBO, it results in a number of very serious problems. First, as I mentioned, it crowds out other investments, which leads to lower output and lower income. Then it leads to higher interest payments, and that means higher taxes and lower output and income. Then it also reduces our ability to borrow, so we get less policy flexibility, and eventually, okay, it increases the sudden chance of a fiscal crisis. Not good for America. So with the accumulated deficit so high, and with healthcare driving it, we have to borrow. But borrowing creates the problem that Secretary Gates mentioned, and this is kind of staggering, okay? In 1970, 5% of the publicly held debt of the United States was held by foreign lenders. In 2012, it was almost 50%, and the total debt had gone up from $283 billion to $11.3 trillion. Okay? Now, who buys this debt? The three largest purchasers of American debt are the Chinese, the Japanese, and the UK, although it's pretty well acknowledged that the UK is a bunch of banks in Britain that are fronting for the Chinese and the Japanese. So who cares, okay? Well, you care a lot if you're interested in national security, because the Chinese and the Japanese ain't the best of friends. If you've been following recently, the Chinese, just as an example, are saying that they own a lot of rocks in the China Sea that they're turning into islands that they're going to turn into military bases. And the Japanese do not like that at all, and there is real tension. Well, what happens if one day the Chinese say, or the Japanese say, whose side are you on, United States? I'll give you the example. We're going back to the 1950s. Eisenhower is the president. The world is recovering from World War II. And the French and the English decide that they're going to invade the Suez Canal because they want more oil to come through. And they go to Eisenhower, and he says, no, we don't do that. You guys shouldn't either. They go back home, they get their armies ginned up, they invade the Suez Canal, totally successfully. Eisenhower calls up the Secretary of State, and he says, I want you to call the Prime Minister of Great Britain and ask him one question. And the question is, who buys your debt? And the answer back then was the United States. We were bailing out Europe, okay? This was the Marshall Plan. And then he says, and if you guys don't get out of the Suez Canal, we will stop buying your debt. And the next day, they left. So what happens if the Chinese or the Japanese say that to us? Not because they're angry at us, but because they want us to be on one side or the other, okay? We are in big trouble. That is a national security problem. So the message is that federal health spending drives the deficit, the accumulated deficit, which threatens our economy and our national security. So what does the ACA do about cost containment? Well, let's start by looking at what it's supposed to do, okay? And I'm not going to go through this in great detail, but federal and state regulators were supposed to implement health exchanges and the Medicaid expansion. There were a bunch of critical policy changes to be implemented. Individuals and small businesses were to get affordable insurance. Government revenues would go up, and there'd be substantial cuts in expenses, and the Medicare ACOs and the demos would be successful and expand rapidly. This is a very, very complicated implementation, and it assumes that everything must go right, and I think as we have seen, everything doesn't go right every time. Let's look specifically at the ACO and cost containment. Besides the direct cuts, and there were big cuts in the bill, there were many different experiments that were supposed to lower costs. Those experiments have had very mixed results. Of the 32 original Pioneer ACOs, there was a savings of $385 million, but 13 dropped out. Of the 220 original shared savings programs, only 53 got performance payments, and the majority lost money. The value-based payment demos had according to academics, little or no effect on spending, and so on. Okay? However, the pressures created by the economic issues, the national security issues, and the law itself have translated transported the responsibility to get this done to the states. And one of the issues you're going to face is what's happening in your state, and if you're multi-state, how different pressures exist in different states. Stakeholders have to adapt to very different environments in different states. There are, to begin with, a bunch of geographic differences: per capita healthcare spending, system integration, health status, and health disparities. But states have made very different choices about very important things. 17 states have state-run health exchanges. 34 have federally run. There are 7 partnerships. And again, the Supreme Court is going to potentially cause some problems depending upon which choice was made. There are different rules, prices, benefits, competition, and policies in different states. Medicaid has been expanded in 30 states, but 17 didn't. 4 are thinking about it. And in particular, as I mentioned, there's the Supreme Court decision and these 1332 waivers, which have yet to play out. Okay? The burden is on state governments and local health plans to make coverage affordable. You're going to be pressured to do that as well. Now, there's some protections that are built in for patients, and they're good protections. A guaranteed issue, comprehensive benefits, the ban on the lifetime and annual dollar limits, rate bans. But plans and states are going to be getting increasingly aggressive as they go through time because the financial protections inside the ACA, the risk corridors and the reinsurance protections, end in 2017. And what we've been in is sort of, I think, the first half or opening innings. It's going to get much more serious much more quickly, and it's going to lead to very different outcomes in different states. Well, what are the techniques that work? I'm going to try to go through 4 briefly. I think you're familiar with all of them, but make some points about what they mean to you. The first and the most important is the move to value-based payment. And over a fairly short period of time, volume is not going to be the solution anymore. Provider performance is going to be reported and measured. The problem, of course, is collecting the data and whether the metrics are credible, whether they're accurate and whether they're the right metrics. And I submit that you have a huge investment in making sure both of those things work out well, and you also have standing because you've been doing it for a while. The second approach is to increase patient cost sharing, and the theory of the case is that patients are going to act more like consumers. I just personally don't believe that works all that well in healthcare, but what has happened is startling. 41% of individuals that have health insurance from their jobs, from working, have deductibles of $1,000 or more. So it's their out-of-pocket for the first $1,000. 43% of the policies that have been purchased on the health exchanges have deductibles of $1,500 or more. So first dollar coverage, which when I was a lad was what everyone aspired to, is not only gone, the size of that deductible is very significant, and people are going to make decisions about costs when they know the costs. The other issue for you, in addition to people wanting to know in advance how much it's going to cost, is collection and bad debts. And ironically, we have more people insured, okay, but so that when hospitals see a person coming in, okay, we're going to get a reduction in uncompensated care, but we're having higher bad debts because of the opening $1,000 or $1,500 that many of these people, particularly if they bought on the exchanges, they just don't have that in their pockets. So this cuts both ways. We're going to see PBMs and PBM-like entities controlling costs by limiting physician options. Formularies will go beyond drugs to procedures and require evidence-based medicine calculations so that we'll pay only if it's consistent with this procedure or this process. And then finally, narrow networks. Now, to the extent that you're in the narrow network, I think that's good news for all of you. The problem is that narrow networks are unpopular with human beings, and they're very unpopular with politicians. Okay? So if you want that narrow network and you want to be in it, you better be able to prove that there's something qualitatively better by virtue of limiting choice. Americans are very big on choice. And you ask a consumer what it means to be a consumer, it means I have a choice. You ask an economist, they'll say, well, a consumer first asks for the price, then evaluates the options and comes to a logical conclusion. Baloney. Okay? People want to have choices. I want the red one, not the blue one, and frequently don't ask for what the price is. But the point is, you want to be able to prove, if you're in the network, that it's higher quality and lower cost, and you have to have very good contracting staff doing your contracting, because there are going to be different kinds of contracts and different kinds of compensation systems in different states, and you got to have good people to administer those things. Now, ironically, or I would say ironically, interestingly, these approaches seem to be working. According to the CBO, their estimates of the 10-year cost projection of the ACA has gone down by $142 billion because of these changes. One comment, though, just in passing, to give you a sense of how important these four things I mentioned are, Doug Elmendorf, who was then head of the CBO, said that if narrow networks are somehow minimized or eliminated by legislative action, which was being contemplated then, these numbers go out the window. Okay? So I think you'll see these approaches pursued. Now, the question that arises, okay, we've got these approaches, what types of organizations are going to be able to live with these constraints and, in fact, prosper? And I've spent my life working mostly with physicians and lawyers. I think that qualifies as a life misspent. But I can say that at least physicians do some good. What all of this means is that I think practicing physicians will face three types of challenges that will require changes in how organizations operate, how cultures exist, and what it means to be a leader. And I'm pretty sure that many of you have lived through some of this, but the vast bulk of American physicians have not. And just because a physician has joined an organization or is now on a hospital staff, that doesn't mean they understand some of the issues that you understand. But let's talk about the organizational issues. Physician organizations will have to achieve measurable results and use transparent processes. The actual form doesn't matter. Most Americans, and frankly most regulators, don't understand the difference between the various forms that exist for organized, comprehensive delivery systems. But what they want is the result. They want comprehensive, coordinated care. They want to see that evidence-based medicine or procedures for making decisions that are understandable and are transparent are used. They want accountability for results, and I think you'll see a big movement toward it's not what you did, it's not the process, it's the result. And then finally, they want you either to take risk, in which case it doesn't matter if you're lower costs, you eat the problem, or lower their costs. Those are the things that they expect from organizations. A competitive marketplace also includes the requirement to increase patient satisfaction, because by and large, patients are not knowledgeable enough to know that these four things I just mentioned are important, and in many cases they don't agree. But they want a good experience for themselves and for their families. But regardless of the form, individual physicians have to support the organizational achievement of these goals. because you can't do this by yourself. You can't do this in a three-person physician's office very easily. So physicians have to invest in the success of the organization and make adjustments to achieve organizational efficiency. I teach at the Harvard Medical School, and that is not on the curriculum. That notion that doctors, once in practice, have to support organizational goals. The second thing that'll have to happen to make the first thing work, surgery is not what I prefer. The second thing that have to happen, by the way, if you have a beard and you wear a tie, everybody thinks you're a psychiatrist. So I have been practicing medicine without a license for about 35 years and very successful. Well, that's okay. So the second thing that has to happen is a change in culture. And this is, I think, hopefully already occurred in most of your organizations, but doesn't exist throughout the United States. We have to see physicians emerging as organizational leaders and managers, not just as individual contributors. In other words, there have got to be a few physicians in the organization who don't simply define themselves by their relationship to their patients. The issue is, what role do they play in the organization? We've got to see physicians and the institutions work together to optimize the entire healthcare system, okay? Which in the good old days, everybody would tell me, not my problem. You know, my problem is my patient, not the success of the system. Well, sports fans, that isn't true anymore. So you've got to do the right thing for your patient, but it's got to be in the context of a broader set of issues. And I think the key is to define or to redefine the term professionalism to include accountability for system and organizational effectiveness, not just as a defense of physician autonomy. The definition of a professional is that they are loyal to the profession and to professional standards as opposed to the organization. If you ask a human being where they work, they will say, what do you do? Well, you know, I work at United, I work at Boeing. You ask a doctor and a lawyer what they do, and they say, I am a physician, I am a lawyer, and I am accountable to the professional standards, which parenthetically I define. So do licensed apprentice pharmacists, but that's another issue. And so if the hospital decides no more red sutures because we can buy blue sutures in bulk, well, wait a minute. You know, I'm responsible for my patient, and I know that blue sutures are the right thing to do, and goddamn it, I want them. And that's professional standards, and that's quality, and that's autonomy, and that's going to be over pretty soon. Third, physicians are going to have to assume organizational leadership roles and functions in addition to being thought leaders. And I teach another course on leadership and management, and you have to pay more for that course than the health policy. But let me make the point. Leaders are people who establish a vision of the future that is so compelling, or who communicate it so compellingly, that other people take action to achieve that vision. That's leadership, okay? Typically, leaders don't tell people what to do. When they start telling people what to do, they screw it up. And there are many, many examples of great leaders who've done that. Managers are people who change the physical reality of how things happen in order to achieve a pre-planned result. They use budgets and they use plans, and they do tell people what to do, and they do hold people accountable. And analysts are people who evaluate the facts of a situation, analyze it, and make recommendations to improve whatever the problem is. Analysts are the people that we respect. Physicians are basically trained to be superb analysts. But the issue in an organization is, once you've analyzed the problem, you haven't solved it. Okay? As a physician, you analyze your patient's situation, and then you take action. You say, here's the treatment plan, here's what we're going to do, and we're going to solve your problem. So just analyzing the situation doesn't do it. You've got to change how the organization behaves. And physicians are going to have to take these roles and have impact in organizations. Now, many of you have already done that, but we're going to need a lot more help. Okay, so what happens if physicians and others fail to make this transformation? Personally, I believe, and I base this on some history, that blunt cuts and heavy regulation is very, very possible. Why do I believe that? The first point, and I'm very good at beating dead horses, because I've said this, is healthcare legislation is never about healthcare. It's about three things. It's about money, 18% of the GDP. That's a lot of money, okay? It's about the role of government, and most Americans would agree with the quote, attributed to Thomas Jefferson, which is that government which governs best governs least. Keep that government out of our health care. Ain't gonna happen, but that's where the fights are. And then finally, it's about social values. And social values is code for things like end-of-life care, abortion, all the issues that tear people apart, but are value issues, rarely healthcare issues. Healthcare costs drive the accumulated debt. It threatens, as I've said, the economy and the national security. And this is my nightmare, that the deficit hawks, the people who are against deficits, and the national security experts will join to say, we got to cut healthcare. The easiest way to do it, and we've just seen it in the sequestration law, is across-the-board cuts. Every organization can take a 2% across-the-board cut, right? The problem is it changes nothing underneath. All you have is less money to do the same crummy job. Worse yet, if you can do 2% this year, you can do 2% next year. As a matter of fact, you can probably do 5% next year while we're thinking about it. So once that starts, it doesn't end and it doesn't help anything. I also think in healthcare, there's the potential for price and, by implication, wage controls. Okay? In other words, the amount of money that physicians, other healthcare providers can get. The result, and this is nightmare territory, would be a uniquely American version of a single-payer system. Now, a single-payer system is un-American. We're not going to do that. Okay, we're against that. But you can dress something up and make it look like American. You can allow the government to regulate just about everything because it's the majority payer, not because it's the single payer. And then you can have administration and healthcare delivered through non-government entities, okay, and allegedly, therefore, keep it market-based. This is what it looks like. Insurance companies become very heavily regulated utilities, okay? Providers become more integrated, but much more regulated. Both the state and the federal government regulate not just insurance companies and providers, but the exchanges. In other words, the way in which healthcare is bought and sold. The federal government becomes a major payer, and parenthetically, governments all in are now over 50% anyhow. Patients act like consumers, not good news. It means they shop, not that they shop wisely. And there are IT platforms that connect everything and provide information, not through you, but through those organizations, to third parties. Now, if the dust were to settle, I'm saying this is where it would settle, but this is America, and the dust never settles. So, big finish. Both public and private payers are going to continue pressuring you to accelerate this transformation. So again, I think the title of your conference is quite appropriate. It isn't. We're not evolving anymore. We got to move pretty quick, and it'll go to value-based care, which is an amorphous term. And again, I would urge you through this organization and other things to try to get involved in defining those terms. Secondly, I think we'll see physicians responding by joining organized delivery systems. I think some of the earlier comments are appropriate, but not all those systems will be successful and not all those physicians will come out in one piece. It will depend on the state that they're operating in and how well the organization is managed. The successful systems will have leadership that has established the culture that I mentioned, and where there is an investment in coordinating care in a way that controls costs and assures a better outcome, and that can be measured. The notion of I'm a professional, and by virtue of having a license, I made the right decision, I'm sure you know that's over, but I mean it's really, really going to be over. Okay? Now, physicians that are unwilling to adapt to this, I think, are going to leave the practice, or it's just going to be very difficult for them to maintain their practices. Now, you have, by virtue of your experience and by virtue of your success, you have the high moral ground. Okay? You got to these kinds of organized, integrated, hopefully accountable and lower cost, higher quality systems before it was absolutely necessary. You are the leaders, and you can share your wisdom. Because again, the people in Washington and the people in state capitals don't understand healthcare, aren't interested in learning about it. It's a loser. No matter what you do, if you're an elected official, somebody gets pissed off. I mean, that's the story of healthcare. So they don't like to do it. Okay? Now, doctors and hospitals have a strange kind of political clout, and it has nothing to do with healthcare. Hospitals are politically powerful because they're a source of local community pride, and much more important, they're usually the largest employer in that community. So it's about economics, okay, and it's about pride. It ain't about health care. Doctors used to have more, but doctors still have a clout because they can complain and lecture people while they're naked and scared to death. It killed the HMO movement. I mean, it works. But even that is lessening because the degree, and I want to be careful how I say this, the degree of respect for physician opinion beyond the delivery of health care has lessened dramatically. I mean, 50 years ago, the local doc was the most respected person in the community. Now, because all the money and all the complications and all the stuff in the newspaper and all the scandals, Americans are learning that physicians may well be human beings as well as being physicians. But you have the high ground, you have the knowledge, you have the background, and I think you're in a position to have big influence. You have to get bigger. In other words, you have to deal with more patients. You have to get better, because as good as you think you are, margins are going to be crushed over time. I mean, literally, haven't seen anything yet. And by the way, I thought that slide that Don put up that showed what's going to happen over the next, 8 or 9 years is a great slide. The only thing you can count on, it will never happen that way. Everything will be changed, and it will be changed to reduce cost. And you have to do it fast. As organized delivery systems who are committed to value-based care, you are our best chance of controlling costs while improving outcomes and avoiding an economic or a national security train wreck. And I am counting on you to deliver. Thank you.
Thank you, Leonard. We have some time for questions here.
Sure.
Let's have a chat.
There you go.
Grab a seat. So thank you for that. That was great, Leonard. 2/3 of the way into your presentation there under the transformation section, there was, I think, on the bottom for emphasis in red and italics, the word, I think, efficiency will dictate the future, not leverage. So I look at that and think to myself, okay, so efficiency is a word. We hear that never in the same sentence with fee-for-service, but we hear the word efficiency all the time in the same sentence with capitation, right? So that being the case, what predictions might you have in terms of the amount of penetration we're apt to see in capitation across the United States going forward?
Well, I mean, the great irony is that as the HMO and managed care revolution was dimming, more and more physician organizations were realizing, organized delivery systems, were realizing that it is the best mechanism if you want to take risk as well as deliver care. And I think systems will be developed, reimbursement mechanisms will be developed that have different names, because capitation has politically bad overtones, but an awful lot of organizations will choose to be capitated, and it gives you the most flexibility. It's a good way to go. So I think it will grow. The difficulty is that until fairly recently, most physician practices and many hospitals didn't know their own financial situation well enough to know where was the right place for them to go. And as you pointed out, they come to the fork in the road and they go in the wrong direction and they get hurt. And that will happen again. There is going to be a lot of collateral damage. There are going to be a lot of organizations that don't do well because being an ACO is a lot harder than it looks.
But so if you look at the ACO program right now, the latest regulations, the next generation ACO, et cetera, it looks clear that Medicare is pushing Medicare towards capitation. That's what we think we see. Would you agree?
Yes, I would definitely agree. I think the buzzwords are organized delivery, integrated, coordinated care, and then very quietly capitation, which shifts the risk. And it'd be great for the Medicaid or Medicare program to be entirely capitated, because then they know how much it costs. And so politically, that makes sense. The problem is, once you move to that, the question becomes, what adjusts the capitation? And you can very easily say, no increase this year, or 0.5% increase in the cap rate, even though healthcare costs are going up by X or Y, and that forces you guys to come up with the savings.
So I ask these questions because if we look at the ACO regs right now, we still see merely shared savings, bundles. Are those a destination that we look forward to, or are they? No. It's just a stepping stone?
Yeah, and this is not evil. This is not like there's
Yep.
some huge strategy to screw the healthcare system around. People are searching for ways to do this right, and it's so complicated that they're trying a whole bunch of different things. But over time, if you have a delivery system that is willing to take risk, capitation is the most flexible way to go, because it allows the delivery system to move the money around, and it's best for the payer because you have a known cost that you're going to deal with. It causes problems inside the healthcare system over the question of who's going to take the risk. What's the role of health insurance companies? What's the role of physician organizations? What's the role of government? So it isn't like you can just snap your fingers, but eventually I think it'll be the preferred mechanism, and it'll be called something else. It'll have a new name.
So why is government not more explicit in either using the name capitation or some alternative name that's a little more palatable? Right now, as everyone is in pursuit of ACOs, we think we know the destination is capitation, full, maybe even global capitation, but they don't say that. Is it just the aversion to the backlash and the stigma associated with the word, or what's the hesitancy?
Well, the HMOs were discredited in the 80s and 90s, and capitation is associated with that. I think there's also a desire to I want to say this carefully, to appear to be more sensitive to the realities of healthcare as opposed to turning into a financial discussion.
Yeah.
Okay? Now, in my mind, it's the physicians and others who run organized delivery systems who ought to be making those healthcare sensitive decisions. And to make those decisions, they need to know how much money they're going to get. The other thing I think they got to do with the ACOs is there's got to be a way to encourage human beings to choose an ACO and stay in it. This notion of being defined as a member after the fact and being able to go someplace else in the middle, that's a bizarre idea, but it's But you can understand it politically. From an elected official's point of view, they know that what Americans want is choice. And cutting off choice is a mistake, so I won't vote for that. So we'll let them go anywhere, and then you guys have to love them so much that they come mostly to you. Okay, that's a magic trick, but you know.
So you alluded to an issue that's really, I think, starting to bubble up, and that is sort of who should hold the risk. So should the risk sit at the capitated physician group, or should it be at the health plan? I mean, do you see a tug of war in that regard, and where do you think the risk ought to be held?
Well, it is a very difficult question to answer correctly. There is no objective, I don't think, answer. It depends on who the players are and what you're trying to achieve. But most physicians who are not an organized, or systems that are as organized as many of your members, don't want to take risk. And where I think most physicians will end up, 20, 30 years from now, they'll be salaried with the potential for a bonus. Okay? But institutions will take risk. To do that, though, you really have to know what's going on inside your institution in terms of care delivery, and you really have to know the health status of all of your members. And I don't want to offend anybody here, but not all of the organized delivery systems that I'm familiar with know that. And if you don't, you're going to get in trouble. And that's what happened to a lot of, HMOs that emerged 10, 15 years ago. I think the same thing will happen with many of the ACOs that have been established recently. They just don't know their numbers well enough, and they also don't have a chain of command to get things done. I mean, if you look at the successful organized delivery systems, there is always a doc somewhere who is not afraid to go nose to nose with the other doc, who either doesn't provide quality care or keeps people in the hospital too long, or uses approaches that are not appropriate, either because of expense or quality. That person is very important, and during training, and I don't offend any, well, I offended everybody, what the hell. During physician training, basically, physicians are taught, you don't criticize the other guy because someday he could criticize you. So you keep your mouth shut. To run an efficient, effective, organized delivery system, there's got to be somebody who tells the truth and takes action, up to and including, you're a fine American, but we don't want you in our practice anymore.
So I was intrigued by your comments regarding a single-payer system. And I think my question is, are we seeing now the first images of basically the American-style single-payer system in the form of these ACOs? In other words, are they the organized systems that you have alluded to that would be subject to high levels of regulation, private, superficially appearing market-based, but or another way to ask the question, has our SGR law effectively created a climate where physicians will be, my words now, rounded up, put into, ACOs or IPAs or the like, and then heavily regulated, an all-payer system? Are we seeing that emerge right now before our eyes? Or?
Let me first, I use that term, the American version of an all-payer, single-payer system, to get everybody riled up. But single-payer is a term like capitation. It's un-American, everybody's against that. Quotes, is never going to happen. What is happening is that government is going to be much more influential than we like to think, because it's paying the majority of the bill. And particularly in HMO ACOs, in Medicare HMOs or in Medicare ACOs, the government is calling the tune, and that is a form of single payer. However, even in Medicare, the way the program works is the plain vanilla Medicare has traditionally been provided through blue plans or through insurance companies. So it'll be that business or that situation where the government is such a large purchaser that it by implication sets the rules, but it will do it through third parties and maybe fourth level parties. Again, I think the issue for physicians is what kind of an organization do you want to end up in, and do you have, if you want to practice medicine, which most physicians want to, and just do that, do you have faith in the leadership and in the organization's ability to collect and analyze data and take appropriate action? My little syllogism about leaders, managers, and analysts, really important. You gotta have a vision of where you're going. You have to have managers that manage to the goals that you want. You have to have analysts to figure out how to do it better and better. And it won't stop. The administration and the management of delivery will be just like the science. It will continue to move over time. And there are going to be all kinds of, I think, breakthroughs with handheld devices where you're going to be monitoring your patients without seeing them. And from a financial point of view, the best way to save money is keep the patient out of the doctor's office. Okay? Another good way is when somebody really needs help, get him in. And I think we're only a few years away from your telephone telling you that. And that would have a huge impact on how care is delivered. So there's a Chinese curse, may you live in interesting times. If you're in healthcare, you are living in the most interesting times we've ever seen. Because the science base is changing, the reimbursement is changing, and the technology to support both is changing. And you got to be in an organization that is for change, not for here's the way we do it, and we're never going to change.
So that's what we need, I suppose. So thinking back to the 80s, there was some physician backlash, and it clearly played a role in the failure of HMO. Yeah, I was intrigued by your slides that talk about the need for physician leadership, a perspective by physicians that they're there not just for the patient but for the greater good of the organization, the emphasis on the need for basically physicians to get on board, I think were the words. So we need all that. Do we have all that? Or
No.
are we going to see the 80s replay themselves, do you think? Or
I think there is the potential for a real train wreck, but there'll be different kinds of train wrecks in different states by different organizations. And there will be organizations that emerge that hopefully will be the models for the future. And this now goes into management theory, which you all are really bored by now. There's some intersection between a model and the people who run the model. And one of the problems in healthcare is that the most highly educated person who gets paid the most money has historically not been in a position of authority to manage the enterprise. So it's backwards compared to the rest of the economy. Okay? And what we have to do is get some people who have that background, have both the training and the intellectual capacity to become leaders at the top. And there are people here who do that, but it's rare. And in many places, both in healthcare and out of healthcare, there's a person at the top who doesn't do what that person is supposed to do. I mean, most people who are in leadership roles aren't leaders. As long as you're all here, what the hell? I mean, you paid your tuition, you know.
so amidst all of, so around my table now at CAPG, a third of my members are owned by hospitals, another fraction are owned by health plans. There's a venture capital firm or two thrown into the mix, and then there's a couple more. We have the whole range. Handicapping, I'm just thinking back here now to the Belmont, the Preakness. So handicapping the models. I mean, do you see one or more or all of them succeeding going forward?
Well, I like to use your term, because I rarely do it. I will handicap the models. I can't predict who is going to be successful, who isn't, because it really depends on that leadership. I once wrote a paper about physician leaders. And one of the things that's interesting about physician organizational leaders is that human beings can't identify them. Only other physicians can identify it. It's a very unusual set of skills. But if you go over the models that you mentioned, the least likely to succeed are hospital-based models. And the reason is the same reason that they flamed out in the 80s and 90s. Well, they did. You know, look at Humana. They sold all the hospitals and became a health plan. The reason is that hospitals have a fixed cost and a physical plant they got to keep operating. And historically, the way hospitals have done that is by increasing the price they charge per unit and the number of units that they sell. The math is very straightforward. That is not a winner if you're trying to be an accountable care organization. So if you have a hospital in the middle of an ACO, you have conflicting goals unless someone has been thoughtful enough to say, we're actually going to reduce the size of the hospital, or in theory, we're going to build such a gigantic network that will keep all the beds full. Very hard to do. Very appealing, very hard to do. So handicapping, not predicting, physician-based model, toughest to do because you got fixed costs and you have a history of solving financial problems by increasing prices and increasing utilization, the two things that ACOs are not supposed to do. Health plans, second model, ought to work a lot better because in theory, the health plan has a huge database and allegedly has good IT systems. He said coming from that industry, but that is added to organized physician-led delivery systems. That's a winner. The problems have been the antipathy, to put it nicely, between the physicians and the health plans. The lack of historic comfort with each other, the lack of trust, and the sort of mathematical models that I think physicians see health plans doing and the kind of sloppy management that health plans see physicians doing. My solution to that is some kind of a contractual joint ventures where the physician organization doesn't try to build the IT system and hire the actuaries and all that sort of thing, but it has a contractual relationship with the health plan to do a lot of that stuff, and the health plan stays out of the delivery of care and says, we've got a relationship with you. So you could see, sort of sub-capitation. We get a premium as a health plan, and we keep, I'm going to regret this, we keep 8% off the top for our, quotes, administration and the other things that we promise to do for you and for the members, by the way. We have call centers and blah, 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 and then we capitate you, the healthcare delivery system, for the rest. And we, by contract, explicitly set out who's going to do what and when. And if those explicit contractual responsibilities are met, then in theory, over time, enough trust is built to make that work. I think that's hard to do, but clearly people are trying to do it. If you're a health plan and you buy a doctor's practice, it gets hard. If you're a doctor's practice and you buy a health plan, that hasn't worked all that well in history. Now, there are some completely integrated organizations. I ran one in the Twin Cities, Group Health, Kaiser. There are some others. If you have the cultural history and if you have the years of success, those are going to be the big winners. But they are very rare. And there's usually some historic quirk that led them to be successful.
So if I'll interrupt, what do you think of the commercial ACOs we have underway in California as being examples of experiments, joint ventures, where there's the kind of sharing that you mentioned that creates the right kind of balances?
If the trust is built, my bet is they will be very successful. But you have to believe you're working with a partner that you can trust and that your interests are aligned. And historically, I think most physicians have felt that the interests of health plans are not aligned with their own. And the health plans have felt that the docs just don't understand. They just don't get the finances. I think you have a lot of people in this room who do get it and are going to be successful. But you have to have been around for a while and know your business. It's real hard to start it up from a dead start and say, we used to be a family practice in Keokuk, Iowa, and now we're an ACO.
Mm-hmm. Hey, my smartwatch is telling me that I've exceeded our time. I'm surprised I haven't gotten a hook. So I'll finish up with just one very general question. So, what would you do if you were running CAPG? What advice? Help me. No. What advice? What advice do you give?
Well, I am available.
Can you write me a script? Can you fill a prescription, please?
As I said, I think you have both the moral high ground and the expertise to be real players in this. I think, and by this I mean the way in which the healthcare system will evolve in legislation and regulation and on the ground. Okay? And I think you want to exploit that. But you want to be very careful. The whole deal in Washington is, every day an elected official has 25 different people coming into his or her office, complaining and wanting this or that or the other thing. And it's always their own self-interest. It's basically more for me. That's what we want. I think you have a potential platform where you can say that, we have whatever it is, members, and based on their experience, these things work and these things don't work. And if some of these things benefit our members, well, that's great, okay? But it's not about, I'm not here to get more for my members, although I am. I'm here to tell you that this will work and that won't. And, you have an almost quasi-academic database here. Mm-hmm. You just don't want to overplay it. You just want to be very careful that you're not seen as the way the AMA used to be seen. And, mm-hmm. I've offended everybody at least twice now. The AMA was at a time, it's nowhere near what it was once, extremely powerful in Washington. That's why we have a Part A and a Part B, actually, of Medicare. But it was always more for doctors. And I think my script for you is we are the future. We've got a whole lot of people that wanted a better way for delivering care. They figured out that integrated, coordinated care is the way to go. They figured out that you can control cost and have a positive impact on quality. And here's what we've learned, and we would like to share this with you. And I think that gives you a very distinctive opportunity. But it's got to be played, and you've got people who have called on legislators and elected officials. It's got to be played just right, or you're just another one of these endless, groups that comes in and wants more money for whatever the hell it is they want, But I think you have right now, I would position, I think you can position yourselves very well.
That is very good advice. We will take that to heart, and we will thank you very, very much. I wish we could go on, you guys. We've got to move on. So thank you, Leonard.